So let's talk a little bit about SALSA. The bill numbers are there at the top of the slide. In the House, it's HR 8188, and in the Senate, it's S4449. And so let's talk a little bit about what is in the legislation, what changes it would make to PAMA. I think important to note the bill is bipartisan, so means there's Democrats and Republicans on the bill, and it's bicameral, so that's why it has a House and a Senate number. This is a really good place for a piece of legislation to start. Passing legislation in the current political environment is challenging, and so that'll be one of the things that we can talk a little bit more about at the end, and if there are questions, as we talk about some of the advocacy that's underway to really try to get SALSA passed before the end of the year. So let's put that aside for a minute and talk a little bit about what the bill does, and then we'll certainly come back to the likelihood of it passing and maybe some of those challenges. So it would be permanent reform to the clinical lab fee schedule. It's not just a short-term fix. It requires that private payer data would be reported from a statistically valid sample, and those are key words there, of applicable laboratories for what they're defining as widely available clinical diagnostic tests. And widely available tests are defined as tests that cost over $1,000 and are offered by more than 100 providers, and that's providers as defined by NPI number. Advanced diagnostic laboratory tests, which was a definition we're familiar with from PAMA, and any tests that are not fitting that definition of widely available tests would retain their current PAMA requirement for reporting, where all labs would be required to report. So those are set aside from the new regulations or definitions under SALSA, and we're focused primarily on those widely available clinical diagnostic tests, which is the majority of the clinical lab fee schedule. First reporting period would be in 2026 under the new statute, assuming it passes this year. And we're going to look at a comparison on the next slide to talk a little bit more about the dates and the cuts within each year that would be possible. Reporting is every 4 years rather than every 3 years as it is currently under PAMA. A couple of key changes in addition to that statistically valid sampling of the data that's actually going to be collected. So Medicaid managed care contracts are being excluded from the applicable data that would need to be reported. So that's good news since those are generally driving rates down. And then we are no longer using the majority of Medicare definition in determining an applicable laboratory. And so they're going to be defined by NPI number, and you don't have to meet that 50% threshold anymore. And this is, of course, the goal of getting a widely available sample of the entire clinical laboratory industry. The legislation actually does specifically call out that it is hospital labs, independent labs, and physician office labs that would be required to report. So again, trying to move away from that large sampling of just independent labs in the original PAMA definition. The low volume threshold remains the same as it was under PAMA. I don't think that impacts a lot of labs, but some very small physician office labs potentially impacted by that low volume threshold, which is the same as it is under PAMA. So I think overall, there's a lot of hope that SALSA will have a lot of positive impacts on both the administrative burden that PAMA caused for labs to report all of your test rates every 3 years. Certainly moving to 4 years is better. But that statistically valid sample is really, really important. And that's really the crux of what SALSA does. And that's really looking at choosing a specific number of test codes that would be required to be reported within each reporting cycle. So reporting won't be based on lab, but rather on test code. So labs would be notified ahead of the reporting period what test codes they need to report on, and then that small sample will be extrapolated out to accurately match the clinical lab industry. So whatever percent of the market is independent hospital and physician office labs would be the calculation that would go into extrapolating that data out to match that full sample. I'm going to talk a little bit on the next slide about sort of what this means, PAMA current law compared to SALSA. This is a little complicated, but I'm going to walk through it, and I think this is the best way I've found to kind of map out what those key differences are. So under current law, PAMA on the left-hand side in purple, you'll see in 2023, highlighted in purple, is our next round of data reporting. And that would be based on data that was collected in 2019, because that's the current data collection period under PAMA. And that would derive new rates that would go into effect in 2024. And so where you see the 2024 line, those rates are derived from the data reporting period at the beginning of next year. And then let's talk a little bit about the max cuts. So as I mentioned, right, PAMA had a phased-in approach for the maximum amount that any particular test code could be cut in any given year. It was 10% for the first 3 years of PAMA implementation. It then goes up to 15%, which is why we're facing a potential 15% cut across certain codes in 2023. And then in 2026, after those 3 years of 15% cuts under PAMA, there is no cap on the amount that any particular test code could be cut. So you see those listed as any. Under SALSA, so these are estimates based on if SALSA were to pass this year. Certainly, if it doesn't pass this year, you could see these timelines changing or getting bumped out into the future. So 2022 remains status quo because we're operating under current law, so nothing there. In 2023, the legislation requires that there's no cut to the clinical lab fee schedule. So this is an added bonus. While we're working to implement SALSA, there would be no cuts in 2023. It also then pretty significantly changes what those maximum cuts could be. And this was something that as NILA and other organizations were advocating with Congress to write the legislation and to try to protect labs. One of the things that was really crucial was limiting those cuts, the cap on those cuts. And so you'll see that the phase-in is much more gradual than under PAMA. There's a potential 2.5% maximum cut, which then goes to 5%. And those 5% remain in the statute permanently, so they don't disappear like they did under PAMA. There's something new under SALSA that didn't exist under PAMA, which is a maximum increase that any one test code could see in a given year. And this was something put in place to help balance the inevitable cost that this legislation will have to the government. And certainly the goal in reforming PAMA is to get rates back to where we feel like they should be to reflect true market value. And that's going to have a significant cost to the government. And so these maximum increases were a way to protect the Medicare program from those potential increases, and sort of a deal-making scenario where we agreed to, that potential cap on increases, really more focused on not having such significant decreases. So the maximum amount that any test code could increase starts at 2.5%, gradually works its way up to 5%, so that by 2027, which is really the first year that new rates would go into effect under SALSA, as you'll see highlighted in red there, data collection begins in 2026, but the new rates would go into effect in 2027, and that would be based on the data collection period in January of 2025, which would be reported to CMS in 2026, and then CMS would derive those new rates, and they would go into effect in 2027. And then that 5% increase sticks there permanently. So no test code could change more than 5% in any given year starting in 2027.